Okay. Okay.
So, sir, it's 3, 2, 1. We are live to the audience. We can start this session. Over to you, sir.
Hello, friends. So today we are going to speak about overactive bladder. Now, overactive bladder, or is it called as OAB, is a very well-known entity, and it is known among many people, and it affects people of all the age groups, from the young persons to the elderly persons. It affects the male and the females in equal quantities. So today we are going to speak about the overactive bladder and what are the recent trends in the management. Next slide. So basically, overactive bladder, it's not a disease. Overactive bladder is an idiopathic situation where the bladder is out of control and it acts contracts very erratically. And instead of the master becoming the person becoming the master of the bladder itself becomes the master, and the sufferer or the person becomes the slave of the bladder. So the person who is suffering from this overactive bladder is forced to map the restrooms in public places on priority basis so as to avoid any embarrassment. Next. So actually, overactive bladder, it's a very huge topic, and it has undergone many changes in terms of definition, in the guidelines, and in the therapy. But still, I'll try to cover the most important aspects of overactive bladder and what are the recent trends in the management of overactive bladder. Next. So according to the Indian Continence Society, that is the ICS, that defines overactive bladder as a clinical syndrome presenting as a combination of these symptoms, which are frequency, urgency, nocturia, and with or without urge incontinence in the absence of urinary tract infection or any pathology. So this definition by the Indian Continence Society of overactive bladder, which is totally based on the symptoms, is accepted worldwide. Next. So this is a 2014 study which was conducted in whole of Asia. They found that 53% of Asian women had symptoms of overactive bladder, and out of that, only 21% seek treatment. So you can see, out of that 53%, only 21% are seeking treatment. That is not really even half the people they are seeking the treatment. So overactive bladder has been reported as many as 1 in 6 women above the age of 40 years of age. Next. So if you see what are the clinical symptoms or the clinical manifestations of overactive bladder. So first we have urgency, then frequency, nocturia, and urge incontinence. Now frequency, that is the person has to go many times to the bathroom, more than 8 times in 24-hour period. So that occurs in 85% of the people. Then second is urgency. Urgency is that it is a hallmark symptom of overactive bladder. Urgency is that you cannot hold the urine. So this happens in 54% of the people. What is urgency is that it's a strong, sudden, unpredictable desire to urinate, and you cannot hold. If you hold the urine, you will feel that some amount of urine will leak back. So that is called as urgency. Next. Then 36% of the people, they have got urge incontinence. What do you mean by urge incontinence? Is that it is the involuntary sudden loss of urine which is associated with strong desire to and sudden strong desire to void. So that means it is the further part of urgency, that is these people, they will have this sudden desire to void and they cannot hold urine. There will be some amount of leakage of urine, which is called as urge incontinence. Then nocturia means waking more than 1 times in the night. So these are the 4 clinical manifestations of overactive bladder, that is frequency, urgency, urge incontinence, and nocturia. Next. Now OAB syndrome is the combination of urgency, increased frequency, nocturia, and urge incontinence, and all these cause is because of reduced voided volume or reduced amount of urine that is passed. Next slide. Now, overactive bladder is mostly idiopathic, but sometimes there can be an underlying pathology which can be associated with overactive bladder, such as there can be an underlying urinary tract infection, there can be an urinary obstruction, there can be cystitis in females, which is called honeymoon cystitis. There can be another type of cystitis, which is called interstitial cystitis. It can be even drug induced as a side effect of drugs. It can be side effect in patients who are having brain disorders like stroke or Parkinsonism or spinal cord disorders. So these are the certain conditions that we have to rule out before we come to a diagnosis of overactive bladder. Next. Now, these are the various causes of urinary incontinence in overactive bladder. So in overactive bladder, it's mainly a bladder storage dysfunction. That is, the bladder capacity is reduced. That is the result. There is incontinence in overactive bladder. Sometimes there can be incompetence of the valves. That is the incompetent sphincter, which can cause stress incontinence. That is incontinence or coughing or leaking or sneezing. Sometimes it can be underactive bladder. That is, it can be hypotonic or atonic bladder. It means the bladder has lost its power. Then it can be a bladder outlet obstruction, which is a bladder voiding dysfunction. Sometimes there can be problem with the nerves of the bladder. That is, it can be a neurological bladder dysfunction. Or it can be sometimes transient causes, like factors affecting the individual's ability to cope up with the bladder function. Like sometimes the patient may be immobile, patient may be lying in the bed, and patient might be having some fracture in the legs. So he might find it difficult to wake up from the bed to go to the bathroom. Or sometimes it might be an old patient who is lying in the bed. So he might be finding it very difficult whenever he gets urine sensation to get up from the bed to go to the bathroom. So before that, if the bladder is full, there might be leakage of urine. So these are some of the reasons for incontinence of urine. Next. Now we will see what are the factors that are associated with overactive bladder. So the risk of overactive bladder is strongly associated with age. So this is a study, and you can see as the age increases, the prevalence of overactive bladder also increases. Next. Now we will see what are the types of incontinence. So first we have what is called as the stress incontinence. Then we have got the urge incontinence. Then we have got the overflow incontinence, and then we have got neurogenic incontinence. Now stress incontinence is due to incompetency of the urethral sphincters. So whenever there is increase in the intra-abdominal pressure and weak pelvic floor muscles, there is leakage of urine on coughing or sneezing. So this is called as stress incontinence. Urge incontinence is due to involuntary contraction of the muscles of the bladder. Overflow incontinence, sometimes there is blockage of the urethra, then cause the bladder to get excessively filled up, and that can cause leakage of the urine. Then we have neurogenic incontinence is due to impaired functioning of the nervous system, of the nerves which are supplying the bladder, like from the spinal cord or from the brain. So these are the 4 types of incontinence: stress incontinence, urge incontinence, overflow incontinence, and neurogenic incontinence. And it is very important to distinguish which is the type of incontinence, because the treatment, it differs from each of the type of the incontinence. Next. Now, to differentiate between overactive bladder and stress incontinence, if you can see, urgency is present in overactive bladder and absent in stress incontinence. Frequency with urgency is present in overactive bladder, absent in stress incontinence. Leakage during physical activity is present in stress incontinence and not in overactive bladder. Amount of urine leak with each episode of incontinence is small in case of stress incontinence, very large in case of overactive bladder. Ability to reach the toilet in time following an urge to void is present in stress incontinence but absent in overactive bladder. The patient can pass the urine before reaching the toilet. Then waking to pass urine at night, that is nocturia, is normally present in cases of overactive bladder and absent in case of stress incontinence. Next. So overactive bladder cases are more prevalent than that of stress incontinence. And sometimes it can be a mixed picture, that is, patient can have both stress incontinence as well as urge incontinence. So the most bothersome symptom should be treated first in case of mixed incontinence. Next. Now, overactive bladder, why it needs to be treated? Because it negatively impacts the quality of life. So physically, it can cause limitation of the activities. Psychologically, it can cause depression or loss of self-esteem. Then socially, there is limitation of social interaction and limitation of traveling around, because the patient, whenever he goes, he has to first find a toilet. Then sexual is avoidance of sexual contact and intimacy because of the presence of, many a time there can be urinary tract infections, or it can be that the smell that affects the sexual intimacy. Then occupational is absence of from work, causing decreased productivity. Here I want to quote that I knew a person. So she was a receptionist and she had this severe overactive bladder, and she had to get up from her place many a times to go to the bathroom, and that affected her work, and ultimately she had to resign from her work. So such is the impact of overactive bladder on the, it can affect your job, it can affect your family, it can affect your married life. Also domestic is that it requires presence, special beddings, special diapers, special clothes. So these are the quality of life, which are factors of quality of life which are impacted by the overactive bladder in a negative way. So that is the burden of the disease of overactive bladder. So that is the reason it should be treated apart from the health points. Next. Now, whenever a patient comes of overactive bladder, we take a thorough history, we do a physical examination, then we do a urine analysis. If necessary, we do a urine culture to rule out infection. We check a post-decedal urine to check for presence of obstruction. And apart from that, we use bladder diary and other questionnaires. Next. Other modalities like urodynamic studies, cystoscopy, diagnostic kidney and bladder sonography, they are not necessary and they are reserved in case of refractory cases. Urine cytology is not recommended in absence of hematuria when the patient responds to the therapy. Next. So many patients, they manage by voiding frequently, by wearing pads, by reducing the fluid intake. 2/3 of the patient, they are symptomatic for 2 years before seeking treatment. 30% of the patients who seek treatment, they receive no assessment, and 80% of the patients, they are not examined. As a result, OAB, it's a hidden condition. Next. So OAB is a condition which is underreported and undertreated, and only a tip of iceberg patients, they present to the physicians and to the urologists. Why? Because many of the patients, they are embarrassed, they have got depression, there is loss of self-esteem, they have got very low expectation from the therapy, and many of the patients, they consider it's a normal part of the aging process. Also, women who are especially housewives who fear to talk to their husbands about the condition, they continue to live with the condition. Next. So, which are the barriers to the treatment? So, patient misconceptions and fears, like patient consider that this is a part of aging process and this is a part of the everyday life. Sometimes patient think that the symptoms are not severe enough for treatment. Sometimes they think that the treatment won't help them, and sometimes they think that it is too embarrassing to discuss about these conditions. Next. So, what are the goals of therapy? To reduce the episodes of urgency, frequency, to eliminate or to decrease the urge incontinence, to ensure that the treatment ensures long-term benefits, and to meet the patient's expectations. These are the goals of therapy. Next. So the foremost and the most important aspect of treatment is behavioral modification. Now, behavioral modification, in this we educate the patient about the condition, we educate the patient relative about the condition, we control the diet and the fluid intake, then we ask them to do pelvic floor exercises, and then we do some bladder training called delayed voiding and time voiding. I'll touch upon each of these factors. Next. So bladder training. So bladder is an organ which needs to be taught. First is gradually increase the voiding interval. So patient should be asked whenever that he should himself try to prolong the voiding interval. If he's going every half an hourly, 1 hourly, he should try to slowly increase the timing by 15 minutes, 15 minutes, and from 1 hour, half an hour, he should make it every 3 hours, 4 hours. Then we should teach coping methods to the patients to hold the urine. Like in female, they can cross their legs, and in males, they can also cross their legs. So, or they can do Kegel exercises, which I'll teach later on. So these are the coping techniques to control the urine. Next. Then we should tell them about fluid and dietary modifications. So they should avoid food and beverages which irritate the bladder, such as tea, excessive tea, coffee, chocolate, spicy, then tomato-based products, then cold drinks, alcoholic drinks. They should avoid the intake of fluid 3 to 4 hours before sleeping. They should empty the bladder before going to sleep or before going out. And they should drink the water in very small quantities. They should avoid constipation. Apart from that, patients who are obese, they should do exercise, they should do weight reduction, quit alcohol, quit smoking. So these are the certain fluid and dietary modifications that the patient has to inculcate in his daily habits. Next. Now, second line treatment is the medical line of treatment. So clinicians should offer antimuscarinic therapies or anticholinergic drugs as the second line of therapy if the behavioral therapy does not help in controlling the symptoms. So in antimuscarinic therapy, we have got many drugs which are extended release tablets, so which can cause lower rates of side effects such as dry mouth. Next. So we have two types of drugs. One is antimuscarinic drugs or anticholinergic drugs. Second is beta-3 agonist drugs. So in antimuscarinic drugs, we have got solifenacin, darifenacin, tolterodine, oxybutynin. Out of that, oxybutynin, tolterodine, these are the older drugs, and newer drugs are solifenacin and oxybutynin. Now we have got newer drugs which are beta-3 agonists like mirabegron. Mirabegron is a beta-3 agonist. It is recently in the market, and this mirabegron does not have any side effects as compared to the anticholinergic drugs. Next. Now, whenever we start anticholinergic drug, we have to have a delicate balance between the efficacy of drugs and the adverse effects. Since anticholinergic drugs, if you give in a very high dose, they can cause adverse side effects like dry mouth, constipation, then CNS side effects like tremors. So you have to balance the dose to create an ultimate so that the drug has got fewer side effects and it is more efficacious in the treatment. So how you determine the efficacy of the drug is that it has lowered the frequency, it has lowered the nocturia, it has lowered the urge incontinence, and it has increased the voided volume. So these are the points where you can see that the drug has acted well. Next. Now, these anticholinergic drugs, they cause very bothersome side effects like they can cause dry eyes, blurring of visions, constipation, dry mouth, reduced cognitive function, dementia in a long term, and unacceptable cardiovascular effects limit their use over a long period of time. So 80% of this patient did discontinue treatment at 3 months period. Next. So there was a need for a newer drug which would be more efficacious, has got fewer side effects, which was tolerable with good compliance, and which was organ selective for the bladder. Next. So then the new drug came was beta 3 agonist, that is mirabegron. So we were trying to improve ourselves with one more drug in the same family. So what we did is that we changed the goalpost. So we changed the receptors upon where the drug is acting. Next. So the drug which is used is now called mirabegron. So this mirabegron is basically a beta 3 adrenergic receptor agonist. So the mechanism of action of mirabegron is on the different receptors as compared to these anticholinergic drugs. So anticholinergic drug, they act on these muscarinic receptors, while mirabegron, they act on different receptors. Next. So this is a study which shows the incidence of side effects of the various drugs. So in this, you can see this oxybutynin having high number of side effects, tolterodine also having side effects, then difenycin having high number of side effects. But mirabegron, it has got very fewer side effects. Next. So recommendations for use of this mirabegron or beta 3 agonist is that if the patient experiences inadequate symptom control or unacceptable adverse side effects with this antimuscarinic drug, then a different antimuscarinic combination should be used, or a beta 3 agonist, that is mirabegron, should be tried. And also it is option for treating symptoms of overactive bladder in patients in whom antimuscarinic drugs are contraindicated, or they are found to be ineffective, or they are having unacceptable side effects. Next. Now, the companies have come out with a combination of mirabegron and sulfenacin, which are found to be more effective than the single dose alone. Next. So these are the various studies. In this, they have compared combination therapy with the single dose therapy. So this is a context study. Next. Also, they have used combination of mirabegron and tamsulosin. Next. So this is a study showing combination of mirabegron with tamsulosin. It showed superiority over just a placebo. Next. So bladder, it has a mind of its own. So very careful and delicate balance between the behavioral therapy, pharmacotherapy will help the patient's mind to win over the bladder. And behavioral therapy, it continues, while the pharmacotherapy, it stabilizes the overactive bladder. Next. So in the end, if all measures have failed, then the last options are cystoscopic Botox injection, sacral neuromodulation, and if the bladder capacity is very small, then augmentation cystoplasty, where a part of the bowel is attached to the bladder to increase its capacity. Next. So just as we inject Botox into the face to reduce the spasticity of the facial muscles, similarly, Botox injections in strengths of 100 and 200 units, this can be injected in the various areas of the bladder. So they can relax the bladder muscles and they can increase the capacity of the bladder. So this is the cystoscopic Botox injections are used in patients in whom the pharmacotherapy and behavioral therapy has failed to control the symptoms of overactive bladder. Next. Also sacral neuromodulation, it is also used in such patients. So that will help to increase the capacity of the bladder. Next. And this is augmentation cystoplasty, where a part of the bowel is sutured onto the bladder to increase the capacity. Next. So OAB is truly a jigsaw puzzle. And as the pieces of puzzles are getting organized, we are coming to know about newer and newer things about the overactive bladder and its management. Next. So in conclusion, the causes of overactive bladder are not completely understood and symptoms may differ and they are confusing. Treatment should be in a stepwise fashion, and treating OAB can be rewarding. For that, a blue clinical history with clinical examination will allow to tailor to the options, treatment options to the patient condition. Though it's a complex condition, many promising newer treatment options are available, but it is essential to diagnose this condition, and you should empower the patients to seek treatment, because many of the patients, they feel embarrassed to speak about this condition. Next. So thank you very much. And if you have any question, you can post in the chat box. Thanks.
Yeah, thank you very much, sir. So there are no questions till now, but can you wait for 1 minute for the delegates?
Okay.
If there's any questions comes. Yeah,
Sure.
thank you. So there is one question in chat box.
Okay. How to prevent overactive bladder? So see, overactive bladder is not like a stone disease. Okay. And who will get overactive bladder, we don't know. But only thing is that you should keep your bladder healthy. So don't refrain from passing urine, and you should not hold the urine for longer periods of time, because holding the urine for longer period of time can cause urine infection. Do Kegel exercises as a part of your regular exercises. This Kegel exercise will help to strengthen your pelvic floor muscles. Avoid constipation. For that, you have to eat a lot of fibers in your diet, because constipation and bladder, they are interlinked. So those people who have got constipation, they naturally end up with having bladder problems. Drink plenty of water, especially patients who are having comorbid conditions like diabetes, age, or who are having past history of Parkinsonism, like stroke disorders, spinal cord disorders. So they should be seeing the doctor oftenly. They should speak to the doctor if they are having any symptoms like urgency, urge incontinence, or having any difficulty in controlling the urine. Because overactive bladder, if it is treated early, so that can prevent the progression of overactive bladder. So in such way, we can prevent the progression of overactive bladder.
Yeah, thank you very much, sir. So I think rest of the questions has been covered up by your presentation, I guess. So there are no other questions. So with your permission, shall we conclude this meeting?
Thank you. Thank you. So I thank everybody for attending this session. And even if they have questions, they can post in the chat box. Later on, we can answer those questions. And I thank Lupin Company for arranging this beautiful session. Thank you.
Yeah, thank you very much, sir. So on the behalf of organizer, I would also like to thank you for your informative and educative talks. Thank you very much for your valuable time.
Thank you.
Thank you. So with your permission, shall we close this meeting?
Yeah.
Yeah, thank you very much, sir. So from here, I'm ending this meeting. Thank you.